arthroscopic subacromial decompression. This is the subacromial space right here. They just take a little roto-rooter thing and go in there and buff it all up, make it nice and shiny. And if you had that hook acromion or you got a little bone spur coming down that pinches it and creates impingement, they take care of that. Distal clavicular excision. A lot of times people who've had stress to their shoulder, it's like Wolf's Law, like we talk about, you stress bone, what happens? Bone grows. So the end of the clavicle will start to grow outward and they lop it on off. Just take an inch off or so, okay? But again, most important thing about this procedure that I want you to understand is nothing is repaired, only taking out bad stuff. So there's no waiting period. We can get it moving. We can, some people will say don't strengthen for 4 weeks. BS. If they're feeling okay, their inflammation's down, they have their range, get after it, because nothing's been affected there. So here is a rough, and it all depends. Phase 1, post-operative, day 1 through 3. You will usually see them in a sling. Doesn't have to be. Yes, ma'am.
With the PTA, will they end up doing that again? Because the bones are not taken?
Usually not. Usually not, unless something happens. Yeah.
Okay, if this surgery doesn't fix anything, we just go in and use that stuff.
Get rid of bad stuff.
Are these patients like more prone to coming back and getting like other surgeries and stuff? Or is this like, I think this will work, this will fix it? If you do the other work.
If this is all that's going on. Now, this doesn't say anything about their rotator cuff, right? Doesn't say anything about their biceps.
But
Doesn't say anything about their labrum.
Are they like more prone to having issues with rotator?
Not necessarily, not necessarily. But because they've had the stuff in here before, they probably have inflammation. They're not just gonna have surgery because they have a hook acromion.
Right.
Because there's plenty of people that have bad acromions because they don't use their arm very much, and need surgery. But if they're doing a bunch of overhead stuff or push and pull, all that kind of thing, it ends up flaring up. So that's when they want to go ahead and take care of this. So, good questions though. So what they're gonna look like when they come to see us, they're gonna have 3 portal sites, okay? They're gonna be some swelling. They usually inject a bunch of saline in there just to filter everything out, okay? Get all the remnants out of there. So they will probably be using ice. They will most likely be in a sling, but not necessarily have to be. I get rid of that immediately. And they may have told them how to do pendulum exercises. All right, everybody stand up with me. Pendulum exercises, one of the things that drives me the most crazy, okay? Is this a pendulum exercise? No, it's stirring the pot, active range of motion, okay? That is not what the goal of pendulum exercises is to make it as passive as possible. Do you have water in here? So it's a little bit of weight. Oh, that's perfect. So I will have people hold something, that dish detergent bottle that's got a little lip on it or something like this, where they can hold it in their fingers. What does this do? Distracts the joint, right? So that's gonna feel great to them. They're gonna love that. Now, I'm not gonna have them stir. I'm gonna have them move their hips to move their arm. All right, everybody try that. Everybody used a hula hoop before? That's the visual I want you to use, okay? Your arm needs to be passive. And if you've got something that can distract, it's even better. That may take your arm off. Now, take it and stir the pot like you're gonna see everybody in outpatient therapy do. That is not passive. It's not. Drives me crazy. See the little old lady over here just. That's not what that's supposed to be. So if you see that, correct them.
What's the point of a passive?
Fluid exchange, a little bit of movement, all good things. Okay? So the first day that we'll see them in therapy, we will do passive range. Okay? We are assessing how much range they have. Okay? Then we can start stretching. But there's no limitation, so you can just keep going on this. Elbow, wrist, and hand exercises. We'll get to this next week. But things like gripping, when I do this repeatedly, what muscles am I using? Obviously flexors, extensors too, because I'm having to open my hand, okay? All of this is a pumping mechanism, because again, they're gonna have swelling here and it's gonna tend to drain down this way. Just doing this helps that fluid exchange occur and get that swelling out of there. So it's a really good thing. Elbow, wrist, and hand. They can do wrist, all kinds of wrist stuff, supination, pronation, elbow flexion and extension. Nothing going on there, so they can do that. That's a great thing. Walking without the sling. This used to be one of my surgeon's favorite exercises. He would get everybody out of the sling and have them walk. Because this gentle arm swing like this, again, fluid exchange, blood flow. We're not taking their arm up and doing all this crazy stuff, but just a nice, simple walking exercise. By week 2, you can start on isometrics. What does that mean?
Where you're just strengthening, especially like the rotator cuff muscles and stuff like that, because you'll eventually advance to bands.
You are contracting those muscles, but there is no shortening of those muscles, right? So I can have somebody do a external rotation against the wall like this. We're just pushing this way. I can have them do internal rotation this way. I can have them do extension this way. I can have them do flexion this way. I can have abduction this way. Any of those are probably going to be fine. If it hurts, I'm not going to push it. Because some people's acromioplasty is different than other people's acromioplasty. If you got somebody who's 75 years old, who's got all kinds of bone spurs and all this stuff, and they go in there and they scrape all that stuff up, you're going to have a bunch of swelling. You'll have ecchymosis that will come down. It looks ugly. They're not going to be able to progress this quickly. If you've got a young person that you're having, it might be able to do all of this even sooner. These are just guidelines. Don't worry too much about these. The phases is really what I want you to think. So then we can move to active range. How do you think we should start active range of motions in the shoulder? It's a great way. It's a great way to do it. It's really active assistive, isn't it? Because they're using their fingers and stuff to help climb up a wall or a finger ladder or whatever. You can take a washcloth and have them push it this way. I'll even start having them do it right here. Just bending forward like this. Yeah.
What about T-bar?
T-bar is outstanding. Again, active assistive. Yep. Really good. Pulleys, we talked about that. Joint moves. What kind of joint moves am I going to be doing here? Number 1, I'm going to distract because that's going to feel great. With all that swelling there, a little oscillation, all that's going to feel good. If I see limitations in external rotation, which you are, what glide do I need to do? Anterior or posterior? External rotation. It's an anterior glide, okay? If I see limitations in internal rotation, that's going to be a posterior glide. If I see limitations in abduction, that's going to be an inferior glide. We'll practice all of these. Scapular strengthening. What's the first scapular strengthening exercise I should have them do? The very first one, the easiest one.
Pinch your shoulders.
Pinch your shoulder blades together. I got no problem with that. I think that's a good one to start with. And then I can kind of work it around, like we did the pelvic clock yesterday. We do a scapular clock. So there's 12 to 6, 3 to 9, and anywhere in between. Okay? Really, really easy stuff. but they don't know that they can do this. They don't know that their scapula moves. I can put them on their side and bring them around this way and have them retract the scapula. I can do scapular mobilization, that's another joint mode. If I see somebody is really bound down, bigger guys, you probably, because of the weights that you've done and so forth, scapula probably doesn't move around your body very well. It may, but I would assess that and we'd look at that. Phase 2, probably in the 3 to 6 week range. What do PRE stand for?
Is it passive?
Progressive resistive exercise. So we took weights in their hand, starting very small, and we'll practice all of these. But we are going to avoid overhead. Why? Impingement position, yes. And you put a weight in their hand, it loads it even more, right? So we're going to avoid that. We get to phase 3, week 6 and beyond, approximately. They should have full range of motion. They should be progressing very well in their PREs. Now we can start talking about functional training. Jasmine asked me the question this morning. How soon do we make athletes do things? Well, let's say I've got a baseball pitcher and they have this. This is a very common procedure for somebody who throws. I'm gonna take them all the way through this, and we get to this 6 week mark. Am I gonna take them out on the mound and have them throw 90 miles an hour? Absolutely not. We may start with tossing a wiffle ball, just to have them get used to the motion, the repetitiveness, the arm angle. I'll take a towel a lot of times and have them snap a towel. Again, just trying to think of getting them into this mode again, okay? But no, you can't jump from A to Z. We gotta go through the alphabet very slowly. And there's all kinds of return to sport protocols and so forth. I'll get you copies of these things. But I want you to make sure that you understand it is a gradual progression. If I see a baseball pitcher with this, and at week 6, we're starting to throw, they're probably not gonna throw off the mound until probably week 10 or 12. So we've gotta
It's
get
like a
this.
trampoline, like it's an angled.
Yeah,
like
yeah. I wish we had one of those. I want to get one of those. I love that. It's a mini tramp that you put on an ankle and you can throw a ball against it. You can throw medicine balls against it. It's fabulous. It's really good. We just don't have a lot of room. It's pretty big. They have a good one in Wadley. So let's get away from the baseball player for a second. What if we've got a painter that's got to be able to paint a ceiling? What's the progression going to be like for him? Is he going to go back to work at week 6? Nope, most likely not. We've got to build his strength up. We've got to build his endurance up. We've got to build up his ability to hold his arm here in that position for a long period of time. Now, painting is not as stressful as throwing, but it is stressful. And it's much more repetitive. Okay? So again, think about the progression. Think about that. Really important. That's the big take-home message there. Any questions on acromioplasty, this procedure here? If you're interested in watching one, there's nothing really to see, because all you're going to see is portal sites, and they'll put the picture up on the monitor, and it just looks like crab meat. They're going in there and heating up. And sometimes you'll see some red, irritated stuff, whatever. Really nothing to see. Rotator cuff tears. This is the holy grail of shoulders here. So there's all kinds of different tears. You can get a horizontal partial thickness tear, meaning it didn't go all the way through. You can get a vertical tear that goes this way. This is a complete avulsion of it. This is what they call a billiard ball appearance. So this is looking down, superior to inferior. If you end up seeing that whole ball like that, you know their cuff is gone, okay? And what happens when something tears? something like this. There's a tensile load here, right? If this tears, does it just stay there? It retracts this way. So if you have a tear of the rotator cuff, usually this is going to be supraspinatus, these fibers, this is infraspinatus fibers here. Those are the two main ones that are going to tear. You can certainly see a subscap tear and a teres minor, but the most popular are supra and infra. So when this tear occurs, whether it occurs traumatically, which is pretty rare, we talked about that yesterday, it's a buildup over time. So they've got a weakened cuff that looks like this, that hurts or whatever, and then they fall and slip on the ice. Or they fall down the stairs and they grab something, and this is now torn. This retracts immediately and becomes atrophied and shrinks more, retracts more. So it's imperative if someone tears their cuff that if they're gonna have surgery to repair it, it's better to do it sooner rather than later. Now, I don't mean like hours afterward, because there's gonna be a bunch of inflammation, swelling, and bleeding, and all those kinds of things. But once that's subsided, just like an ACL we talked about, they need to get this fixed if they're gonna do that. Okay, yes?
Is there a point to where somebody's torn it so many times they're just like?
Absolutely. Inoperable tears is what we talk about. So if this has happened, and you see this billiard ball, and this thing has retracted even more, and again, we're talking about tiny, tiny tendons, okay? You see, here's the muscle belly. Well, the tendon is probably, a tenth of wide as the muscle belly. So they're very small. So they tear and then they retract. If they get to the point where it's a few centimeters, like if it's an inch retracted, there's no use in having the surgery, because you're not gonna be able to tease this thing out, stretch it out, and then suture it. It just doesn't work. That's when they start talking about reverse total shoulders. We'll talk more about that in a little bit. Where the deltoid actually helps to lift the arm. So again, there's a continuum of all these things. So this is kind of what a repair would look like. They will make holes in the bone, and they will thread this through, and then they suture it and anchor it to the bone, okay? Very delicate surgery, hard to do arthroscopically, but it's done now almost exclusively arthroscopically. But they will dig this little trench here, just like I said, and suture that to the bone. So therefore, we do have a repair here. We have got to wait 6 weeks before we put a tensile load through this bone, through this tendon that has been repaired, okay? We cannot do anything to bring about a contraction of this before that, because you can tear it right there. We need time for these sutures and the anchors to mature. Factors to consider. Probably one of the most important slides here. And again, this was meant for DPT students, but I want you guys to understand it as well. When we have a rotator cuff repair, what is the philosophy and the expectations of the doctor? So your therapist needs to communicate with them. This is somebody who, I had a guy who fell through a drop ceiling. He was working at Wake Forest, and he grabbed one of the joists on the way down and just yanked it completely out, okay? He was young, he's 30 years old. They're like, oh yeah, he's sutured down, he's good to go. You can be almost as aggressive as you want to be. As opposed, we got an 80-year-old man who slips and falls, sticks his arm out, a foosh injury, well, it not only breaks his wrist, but it tears his rotator cuff as well. What is the expectation there? He's a smoker, he's diabetic, all these things. His tissue is terrible. It's not gonna go well. He might not even be a candidate for surgery. So that's two completely different ends of the spectrum there. Yes, ma'am?
What do you do in that situation though, since he broke his wrist too, and like you were talking about starting with
You know, there's like.
Yeah, you can't start doing this,
So, like,
can you?
what do you start with?
It's really hard. That's when you just start working on scapular stuff as best you can. Maybe his elbow, maybe you can do some things with that, but it's really hard, really, really hard. That's when I would want, if it's my choice from a rehab standpoint, do one and get it right and then worry about the shoulder. And that's what usually they'll try to do. The size of the tear, we talked about that, right? We saw different sizes of tears here. If it's a massive tear, you're gonna slow everything down in rehab, okay? And that's something that's gotta be communicated. We don't know, do we? We don't get to watch the surgery. We've got to be able to look at an op report or communicate with a physician that says, yeah, this was a 3 centimeter tear, it was huge. We gotta go slow. Arthroscopy versus open, there's very few open incisions anymore. I'd say 95% of things are done arthroscopically. The age of the patient and the quality of the tissue kind of go hand in hand. Obviously, someone who's older is not going to have as good a quality of tissue. But when I mean quality of tissue, what else influences that? I just mentioned a couple of them. Age,
Lifestyle.
lifestyle. If they're a smoker, they're going to have poor tissue quality. Diabetes, comorbidity that greatly affects tissue quality and healing. Occupation, we're talking about patient goals right here, exactly. If this is somebody that's got to get back to doing things overhead, we treat them completely differently at the end of their rehab than we are somebody who wants to be able to sit and type at a keyboard. Okay? Hugely important that we understand all these things, okay? Because that's going to determine how we progress. So, again, gotta communicate. First 4 weeks, pretty similar to what we saw with the arthroscopic decompression. The sling would probably be different. Have anybody seen these abductor slings that they use now? There's a big pillow like this and so forth, as opposed to just a regular sling that just kind of holds them wherever they want to be. The abductor sling has been proven to get better healing here because the arm is on a slightly abducted position, a little better blood flow. Try to say that fast. But again, pendulums, elbow, wrist, and hand, if there's nothing else concurrently going on. Very similar. The first PT visit is usually around day 4 to day 7, although the trend is now, especially if it's a larger tear, to not send them to therapy for like 4 to 6 weeks. Okay? Because they want to make sure that repair is solidified, it is taken to the bone. Okay? So what are you gonna see if you see somebody 4 to 6 weeks after their surgery?
Really
Super stiff. Super stiff. But I will tell you this, the re-tear rate of those folks is much, much less than the ones they send to therapy immediately after post-op. Yeah.
So how much is distraction at day 4? Like, is that really safe?
Absolutely. Feels great. We're not talking like this
No,
kind
I
of thing. It
understand.
is just very gentle. But again, the amount of swelling that they have and so forth, just that little bit of joint distraction, they will greatly appreciate. Passive range, we've talked about it, wrist and hand, pendulums, ice and E-stem, abduction splint 24 hours a day, recliner to sleep. One of the first things I tell somebody, if I get to see them post-op or pre-operatively, which we do a lot of times, because a lot of times they'll come to therapy, if it's not a full thickness tear, a lot of times they'll come to therapy to see if they can avoid surgery, which those are the really fun cases for me, because you really feel like you're making a difference then. But if they have to have surgery and we know it's coming, the first thing I tell them is, do you have a recliner? Because there's no way on earth that you're going to sleep laying back all the way supine or sideline. It doesn't happen. Probably for a month, they're going to be spending time in that recliner, or if they have like a hospital bed or something that props up like this. If they try to lay flat and that cuff relaxes and everything, oh, Talk about waking somebody up. That is miserable. So they need to get comfortable in that recliner. Phase 2. So now we're talking about the time after the repair has healed. And I would really prefer if that's in 6 weeks to 8 weeks, to be honest with you. Now we can start doing some stuff with some contractions to do, okay? Isometrics in that neutral position we talked about. Scapular strengthening, rhythmic stabilization. Most of this is very similar to what we did with this procedure. It's just later in the time frame. Wean them from the sling. I want to get them out of the sling as quickly as I can because I don't want them getting tighter. They love the sling. They love it, but they hate it, if it makes sense. I've had many sling burning parties. We had a little fire pit out behind our clinic. They would love to throw stuff in there. The distraction passive range modalities, at this point, if it feels good, do it. They love their stem and their ice and all that good stuff. That's fine. So we get into this more advanced strengthening from isometrics to this PRE, okay? If they've been in a sling for a long period of time, external and abduction will be tight. But that's part of the procedure too. When they suture down that rotator cuff, they make things tighter. They make the capsule tighter. So it's okay. You're gonna have to expect that. It's not a lot of fun for them when you start stretching things out a little bit, really get more aggressive, but it's all right. I'd much rather deal with a stiff shoulder than a retorn shoulder. That's not any fun. There's our friend here. What does that stand for again? Proprioceptive neuromuscular facilitation. So our PNF, we'll practice this in a few minutes. We'll do some contract relax, we'll do some rhythmic stabilization, all that kind of thing. But again, very careful with the overhead activities, not pushing them here. And again, keep in mind, all of these dates and so forth, weeks out, and all that stuff is variable. I would rather you be conservative when it comes to this because I think healing is so important for the cuff. This is one of the rehabs that has gone back in time and we are more conservative. We should be more conservative. It's not progressive. ACL rehab used to be 12 months. Now they've got that down to 6 to 8 months and so forth. This one, don't push it. Let it come naturally. Beyond 12 weeks, we can start some functional training, closed chain stuff like push-ups, push and pull activities. Isokinetic tests, what are those? So you put them in this $40,000 machine and they will move against resistance at a certain speed and all this stuff, and it will tell you, hey, your right shoulder external rotators are 60% as strong as the ones on the left. Okay. But again, you're not gonna see many of these machines anymore. What's that? Very. So you're not gonna see many anymore. We start talking about their criteria to return to work and to sport. And again, 12 weeks is pretty aggressive, really. I would say this is probably more along the lines of 4 to 6 months for discharge. Now, there's other factors that happen here too. What if you have somebody who has 20 visits per calendar year approved? 20 PT visits. We already said this is like 16 weeks of PT. How are we gonna fit this into here? And they will come once a week?
Home exercise plan.
Tell me what would be your ideal scenario if you got this? How are you gonna fit that in the 16?
I would make this homework program more aggressive in a sense. And like
Front end or the back end?
the back end.
When do you wanna see this patient the most?
I do it more
First.
like
Supposed to
post-op,
be
and then as you know, can the treatment, I would lessen the visits because of people.
Okay,
Cause you would wanna be like aggressive a little bit if you see quick. You don't wanna push it too hard, but you wanna advance them.
I would say this, I would do just the opposite.
Yeah.
The opposite.
I would bring them in immediately post-op, one time.
Yep.
I would show them pendulums. I would elbow, wrist, and hand, give them all their precautions, tell them about sleeping in the recliner. I'd probably see them once a week for the first 6 weeks.
Yep.
Because really, I can't do much. As long as they're not getting super stiff. Now, there's something to do. I would see them one time a week for the first 6 weeks. That's my preference, if this is what I have to deal with. Okay? And then that next 6 weeks, I'm gonna see them at least 2 times a week. So that would be 12 visits. So 6, that's 18, and that gives me 2 in the last, then I start weaning them down a little bit. But this is when I really want to make a difference. Is after that 6 week mark. Now, if you get somebody who's got unlimited visits, you can see as often as they want, you know.
So you want the most visits when they're just starting to do like function.
And they're strengthening. Yeah. For me, that's what I think. Again, you're not gonna see that in a text somewhere. That's just kind of the way I've learned to deal with these things. All right, let's take 8 minutes. Be back at 10:05.